My name is Dr Anvith S Shetty. I'm a consultant orthopedic surgeon. Majority of our patients that we get are in the age group of 55, 60, and 60 plus. So these patients come with knee pain. So what happens in these patients is the knee joint, which is a hinge type of joint, we call it as. So the knee joint is worn out because of lot of use. So the knee joint is covered by something called as cartilage. With age, after using it for a long period of time, the knee joint starts getting worn out. Now, once it is worn out, there's no cartilage. The bone comes and sits on top of the other, one on top of the other. Now, that is why the patients have a lot of knee pain. So that is the reason patients have knee pain in old age group. Before, there was no knee replacement. Maybe after 1970s, it has started coming. So what do we do in knee replacement basically? Like I said, the knee is a hinge joint. Now this is worn out due to old age, due to degenerative changes, or excessive use of this joint. The knee, the cartilage which is covering the knee is worn out. Now there has to be a solution for this. Now we call it as knee replacement. We do it. So what do we do in knee replacement basically? So like you see this knee joint, right? So you have a above bone which call as femur and a lower bone which you call as tibia. So what do we do is the worn out part of the knee, that is the distal part of the femur, that is the lower end of the femur and the upper end of the tibia bone. We remove it and we replace with a metal. So we call it as metal on metal. There are different types of implants that come. We call it as metal on metal, metal on poly, or cobalt chromium. So different types of implants are coming. So we remove whatever is the worn out part of the knee joint and we replace it with a metal, so that the patient has good amount of movement and no pain. So we basically aim to achieve a painless, stable joint. Now this is total knee. So what is partial knee replacement? So usually what happens is in our knee, we call it as medial, which is the inner side of the knee, and lateral, which is the outer side of the knee. So our medial part of the knee is usually has a tendency to have the more weight bearing portion of our knee. So that it tends to get worn out more with age. Now in partial knee replacements, what do we do is we remove only the medial part, the inner part of the distal part, lower end of the femur and the upper end of the tibia. We replace only that with a smaller incision. In a total knee, we have an incision of about 15 to 20 centimeters. But in a partial knee, we have a smaller incision and a smaller implant. But there is chances of getting further. You can always get converted that to a partial knee into a total knee. So you will need to go for a second surgery also. That is the only disadvantage of the partial knee. We grade our knee pains. We grade when we take an X-ray. Whoever comes as a patient to us, we take an X-ray first. We see initially clinically we see the patient, and then we take an X-ray. When we take the X-ray, we see how much amount of worn out is there. So we grade it mild, moderate, severe. And in severe grade is where I would recommend a knee replacement. So in severe grade, what happens? Whatever there is a space between the two bones of the knee joint, the upper end of the tibia and the lower part of the femur. So how much worn out it is, the grading is given based on that. So when there is severe, we call it as osteoarthritis. This severe osteoarthritis means there is no gap between the two bones. There is no cartilage covering the two bones. The bones are on top of the other, and there is no gap. And along with that, there is something called as deformity. Deformity meaning the leg is bent either inside or the leg is bent outside. So these are the conditions where absolutely you have to get a knee replacement done. Whereas severe osteoarthritis is there where there is no gap, along with a deformity of the lower limbs. That is where you do a knee replacement. There are a lot of sports activities are there. So usually patients come to us at 20-25, they come to us with menisci injuries. Menisci is basically a covering over the tibia, which is on the knee, which forms a knee joint. So the menisci is a covering. Now patients come to us with meniscus injuries. Initially 15 years back or maybe 10 years back also, the mode of treatment for these meniscus injuries were either plaster and you would always have that locking kind of pain. And if not, you do an surgery, arthroscopic surgery or open surgery, and remove the degenerated menisci. Damaged tissue used to remove it. We used to call it as meniscectomy. So, but these patients used to have no menisci. So they used to have more chances. Early degenerative changes used to be there for these patients. And now treatments have changed. But before, these patients now who were operated 10, 15 years back with for meniscectomy have a chance of getting degenerative changes now. So what happens in these patients is, see, it depends. Like I said, if it's a severe knee and he has a deformity in his knee, yes, he needs to get operated. But one thing has to be kept in mind, that there's a lifespan for everything. What is given by God is the best. What we do is always second. So we do a replacement. It has its own lifespan. Usually a knee replacement has a lifespan of about 20 to maximum is 25 years. So you do a replacement at the age of 45, the patient will go for a revision knee at the age of 70 again. By the time he's 70, we fix the implant with cement. We put a bone cement, we call it as, and we fix the implant to the bone. Now the implant starts loosening, implant starts getting weak, and it will start getting loose, and patient will have again pain while walking. Once the lifespan is over, you will have to do a revision surgery. So the ideal age to do a knee replacement is actually at around 60, 65. That is the ideal age, because 25 years from there is around 90. The patient post 90, you know how much more mobility the patient will have also will reduce drastically. So that you can at least accept. We again classify our patients. So once they get operated, we have a protocol to follow. Initial 2 weeks, this much amount of physiotherapy, this much amount of knee bending and muscle strengthening exercises we teach the patient initially. So what happens is post-surgery, we dissect the muscles. So we need to strengthen the muscles back. So we ask the patient to do, like I said, quadriceps exercises. So push the knee down, strengthen his muscle. So we do a lot of quadriceps exercises so that his muscle strengthens. Then this is in the initial 2 weeks. We strengthen his muscles. We get his knee range of movements back. The usual range of movements of knee is 0 degree to 130 degree. So this is, for example, this is 0 degree. This is the 130 degree movement. This is our normal knee. This is how much we can normally use. Post knee replacement, we make sure that the patient achieves at least 90 degree by the end of first 2 weeks. After 2 weeks, we advise him to do even more. We encourage him to reach around 120, 130 degrees post 2 weeks. 2 weeks to 4 weeks is the time we get this along with the quadriceps strengthening. Initially, see, post knee replacement, our main aim is to make the patient walk without pain. Next day of surgery, we are going to mobilize the patient. We'll encourage the patient to walk, mobilize the patient as much as possible post knee replacement. So by 4 weeks, we expect the patient to get a good amount of knee motion, range of motion, along with the muscle strengthening. Initially, we put a brace so that the patient walking with a walker, end of 4 to 6 weeks, the patient wouldn't have a walker also. He would start walking without a walker. And maybe 3 months, he will be used. We would advise only walking, no running activities. Post 3 months, once he gets used to accustomed to his new knee, he start running activities also. Post surgery, physiotherapy is the most important part for especially post knee replacement and post any sports injuries. Maybe giving a surgeon a credit for a surgery is for his post-op care, because any surgeon can do a knee replacement. Any orthopedic surgeon can do a knee replacement. But getting the patient to do a good amount of physiotherapy to get the patient back to normal, that is a big procedure. That takes time. Even patients need to understand it takes time. There are some patients who are not receptive to physiotherapy because of the pain, because of various reasons. They don't have much encouragement. So doing a physiotherapy, making sure the patient does physiotherapy according to the timeline, if not encouraging the patient to do a good amount of physiotherapy is a must for any patient. That is, like I said, 4 to 6 weeks, that's 1.5 months of just physiotherapy you need initially to just walk. Then with a walker, and without a walker, another 1.5 months. So 3 months of, rigorous physiotherapy to get you back to being that normal. It takes effort from the patient. Like I always say, till surgery is a doctor's job. Post surgery, it's always the patient's job, because it's about how much effort he gives, how much he makes sure that he wants to be back to normal. It's always in the patient's hand. And we always prepare our patients in such a way that they know that they have to undergo a rigorous physiotherapy post getting operated, and they should be okay with doing all that. Post surgery, the biggest headache for any orthopedic surgeon, especially replacement surgeon, is going to be infection. So he would maintain absolute sterility, he will maintain. But post, once he is operated and the patient is out, we will always ask the patient, we usually remove the stitches at 2 weeks. So we'll always ask the patient to make sure there is no waterfalls on his wound. He doesn't go hit his lower limb anywhere or nothing fall. He takes absolute precautions to avoid any damage to that operated area, any water spills, usually any infections, any urine. We usually put some patients, we put a catheter, some patients we don't put a catheter. So the patients pass urine and it might seep through and it might cause infection. So maintain absolute sterility when you're at home. Also make sure you use your washrooms regularly. Don't dirty your bed. And like I said, infection is the first and foremost thing that we are always worried. So once 2 weeks after that, the other worry is patient shouldn't do aggressive physiotherapy. You can't expect you to run at 2 weeks. You cannot. You have our protocol, like I said, 3 months it takes for a patient to walk. Without walker, it takes 6 weeks. With walker, it takes 6 weeks. Without walker, after 6 weeks, he'll start walking till 3 months. That is till 12 weeks. After that, only the patient can run. So patient needs to realize that there is a specific timeline that he has to follow, and he has to be in that timeline itself.